Hi everyone, this is Dr. Deeksha Pandey and these are our two fellows. Hi, I'm Dr. Suvriti.
I'm Dr. Dheera.
We are here for a case discussion for all of you. Ma'am, you want to take it from here?
Yes. So, we are going to present a different kind of case today. The reason why I say so is that urogynecological problems are basically related to quality of life issues, and they are never will be a wrong word. I say they are 99.99% quality of health related, and they are 0. Very rarely there are killer problems. Okay, so what I mean to say in simple words is urogynecological problems, if you have, your quality of life may be deranged to a certain extent. However, usually they will not kill you or your loved ones, but there are rare incidences where it can be a lethal problem also, and one such problem we are going to discuss today. So, can you think of some conditions which are related in urogynecology and can be lethal complications?
Ma'am, hydrouretronephrosis leading to
Hydrouretronephrosis, not because of any reason.
Yeah.
What urogynecological problem can cause hydrouretronephrosis?
Ma'am, prolapse.
Prolapse. So any kind of prolapse or wall prolapse can cause hydrouretronephrosis. Why, Dheera?
Ma'am, due to advanced prolapse, if the bladder is, if the anterior vaginal wall is pulled down, when the bladder is also pulled along, the ureters can be kinked, and if the ureters are kinked, there can be obstructive uropathy.
Yeah.
And that's
So
it.
easier way to understand this will make it a little easier when the uterus slips down.
Yes, ma'am.
Uterine arteries also get pulled down. And you know that uterine arteries are at the level of internal os, just cross the ureters. So when the uterine arteries pull down, they also put pressure or kink the ureters in it.
Yes.
And uterine arteries don't get blocked because they are usually
Tortuous.
tortuous.
Tortuous,
Okay,
yes.
so they have some tensile strength, but it is very easy for ureters to get kinked at a certain point and cause hydrouretronephrosis.
Yes, ma'am.
And in my entire career, I started from my PG days, I have seen, I will not say many, but I have seen a few women who have presented with renal failure
Yes.
because of
Long-standing,
hydronephrosis caused because of prolapse.
Yes.
It's not a common problem, but it happens rarely.
Yes.
So something similar we will be discussing today. But before we start into the conversation of the case, can you tell me a few more conditions in
Yes, ma'am.
urogynecology which can kill a patient?
Conditions in urogynecology which can kill a patient.
Those are related to prolapse basically.
Okay.
Were you thinking of something else? You can share that.
I'm not sure, ma'am, but I was thinking if in the case of urethral diverticulum, when we send it for a biopsy, if it comes with bleeding.
So urethral diverticulum itself is a rare thing.
Rare thing, yes, ma'am.
And malignancies are rare in that, rarer in that.
Yes, ma'am.
So something which is a little bit more common. So maybe related to malignancy. Should I tell you?
Yes.
Yes.
Ma'am, in the prolapsed mass.
In the prolapse
Yes,
mass. So when I was undergraduate and postgraduate, which was a few years ago, so the teaching was a little different. I was taught that there are two conditions where prolapse will not occur. One is PID and one is pelvic malignancy.
Okay.
Why? Because of
It will be pulled
fibrosis
up.
and adhesions, prolapse will be pulled
pulled
up.
up. Yes.
So
ma'am.
these two conditions we were taught you will never see in your life.
Okay.
But in real case scenario, real life scenario, it is, I have seen those kind of cases, and now as the awareness is increasing and maybe we are seeing more and more women coming for seeking help. So I have seen, again not many, but yes, few cases where I think 3 to 4 cases when patient had procedentia or
Okay.
third degree uterine prolapse, and they had uterine malignancy, endometrial malignancy with that.
Okay.
I have seen 4 to 5 cases where prolapse was associated with cervical cancer. So it's not that it might be a rare finding, but that dictum which was taught to us, maybe somebody knew it, maybe somebody had taught you also, the dictum has gone now. It is no more a rule, as we are seeing more and more women like that.
Yes, ma'am.
So if uterine malignancy, that is endometrial cancer or cervical cancer, is there, they also may be
Associated with prolapse. Yes, ma'am.
prolapse. So just saying that some women, if people are talking together that mass per vaginum, it is a benign condition. It is not always so.
Yes.
It can
Be associated with malignancy
yes,
also. Yes, ma'am.
associated with malignancy also,
And grave renal problems.
renal diseases also. Okay. So with this background, today we are going to discuss something in similar lines.
Yes, ma'am.
So who will present the?
I'll tell about the history, ma'am. I'll try to keep it as short as possible because it's a long story.
Yes.
Yes, ma'am. So we are going to present the case of Mrs. X. She's 67 years old, hailing from Manipal, belonging to low socio-economic status. Ma'am, she had come to us with the complaints of mass per vaginum since 20 years. Before that, she had no known medical disorder before this, and she had undergone a total abdominal hysterectomy around 25 years back in view of AUB due to leiomyoma. Now, since 20 years, she'd had this complaint of mass per vaginum, and she gives this history, ma'am. It was progressive in size, and through the day, it would increase at the end of the day and increase with activities. But now it had reached a point where it was always out since the past few years, and it was increasing after that. And initially, she could also reposit it. So around 2 months back,
It's a very interesting
yes,
history.
ma'am. Yes, ma'am. So around 2 months back, she had come to our hospital in view of, not because of this, she had come because she had fever, burning micturition, and breathlessness. At that time, ma'am, when she was evaluated, she was found to have cardiac problems. She was found to have severe left ventricular dysfunction, globular heart, hypokinesia of the heart. So she was admitted under cardio. And then they had sought a consult in view of this mass per vaginum because she had a severe UTI picture also at that time. So in view of all of that, mass per vaginum along with recurrent UTI, they had sought a consult with us along with the Urogynecology unit. So when we examined her, we also noted that she had gross bilateral hydroureteronephrosis, and she had this mass per vaginum, which was at that time when we had seen her around 2 months back. We were able to reposit that mass. She was not comfortable and a cooperative patient, but there was no problem there. We could reposit it. It wasn't resistant to that. And we had at that time, looking at her comorbidities and everything around 2 months back, we had given this plan that we were probably going for an obliterative procedure, and we'd asked for bilateral DJ stenting. Now, there is another twist to this story. She underwent this stenting also, and she went home. She was planned for surgery a month later because we wanted all the cardiac complaints and infection and everything to settle a little
More
bit.
than that, actually, that's what we told to the patient.
Yeah.
More than that, we were not having dates.
Yes,
For
also that.
So,
Yes, ma'am.
OPs were booked for
And
2
her
months.
insurance and so
Yes.
many things.
To
apply
buy
for-
time, and
Yeah.
it was not an emergency. We told her to come
go.
after a month or so.
After a month. But ma'am, she came in a little early, like a week before her tentative date, because she had severe pain abdomen. When we had examined her that time, we saw that the mass was still out, but it had like a tender feel to it, and we tried to reposit the mass and we couldn't. At that time, it was very difficult to reposit it, and we had to put jelly and counsel her so much, and finally we were able to place a tampon and reposit the mass. And when we got an ultrasound done at that time, and we saw that the stents had migrated completely, and they were seen in the in the pelvis. So again, we revised the plan and we decided that
Actually, that we'll discuss
come to
little
that.
later.
Yes, ma'am. But
Okay.
this is basically what happened with her, and we were able to reposit it with difficulty.
Okay, so I'll summarize this case
Yeah.
history for you. What Sov has told. She was a 67-year-old
Yes, ma'am.
lady.
Yes, ma'am.
Her hysterectomy was done abdominally for
Yeah.
leiomyoma 25 years ago.
Yes, ma'am.
Within 4 to 5 years of that, she developed a wall prolapse.
Yeah.
Which was increasing in size in all typical history of wall prolapse.
Yes,
She
ma'am.
gave that increases in amount of pelvic
Yes.
floor
Yeah.
disorders without uterus. That means the diagnosis you can make out in history only that it was a case of wall
Wall prolapse. Yes,
For
ma'am.
20
20
years, she
years.
was having a wall prolapse which was increasing, which
And-
patient has realized that, but she
Yeah.
did not come to seek
Yes,
help.
No,
ma'am.
ma'am.
And what happened, this is very important to understand, that she ignored it till the point that the ureters got kinked. Because of that,
Yeah.
she had hydroureteronephrosis
Nephrosis.
because of that, which got infected and developed. Maybe if 10 years ago only we would have done,
Yeah.
her age would have been 57 that time,
Yeah.
and maybe she would not be having so many
So many
cardiac
comorbidities.
risks.
Yes,
Okay?
ma'am.
The surgery would have been very easy. One is that
Yeah.
that story. The second thing, it's not just that her surgery was easy because of her comorbidities or not. The
Yes,
other
ma'am.
thing what happened, that in that waiting time, in that ignorance time,
Yeah.
her prolapse became
Much more advanced.
much more advanced, and finally to the ultimate stage, which we call as incarcerated
Incarcerated
prolapse.
Yes,
That
ma'am.
when she was not able to, even when she tried, she was not able to
deposit
it into her vagina and into the pelvis.
Yes, ma'am.
And when she presented to us,
Yeah.
you know how difficult,
Yes, ma'am.
how
Yes.
much difficulty we had
Yes, ma'am.
in
Repositioning, yes, ma'am.
repositioning it inside the vagina and the pelvis. So this was her story. From Dheera, I want to know, well, tell what happened after that and the technique of repositioning the mass inside. But let's ask, are you going to tell me the examination finding, how you saw
Yes,
it
ma'am.
when she presented in the emergency that
Yes, ma'am. Ma'am, when she came, she was
For the second time, ma'am. Like when we admitted her.
right.
She's-
Yeah. When she came, she was in extreme pain, ma'am. When we saw on local examination the
So
prolapse.
general condition was?
Ma'am, general condition was poor.
Hmm.
Yes, ma'am. Her pulse was 90 beats per minute. BP was 130/90. Otherwise, her cardiac, she was having, like, because she was in heart failure, she was having a S3 sound, and otherwise there were no crepitations, ma'am.
But she was not looking,
Yeah.
when she came to us in OPD, though she
Wincing
came
in
that
pain.
her general condition
She
was
was
not that.
not that good. Yes, ma'am. She was in pain. Yes, ma'am. On per abdomen there was no tenderness, but on local examination the prolapse was outside with complete vaginal eversion, and it was edematous and it was tender on palpation when we. Yes,
So
ma'am.
two complaints. I don't know whether you took it or not. When I was
Yes, ma'am.
talking to her on that day, her relative told me two more important problems. One was because of the mass, she was not able to sit. She was shifted to us in trolley, if you remember
Right, yes,
that.
ma'am.
She
was on
said
the trolley.
a lot of problems she's having because she's not able to sit properly.
Yeah.
Did they tell you this problem?
Yes, ma'am.
Okay.
Even
Yes.
while she was admitted, she was not able
Not
to
able.
anything which was putting pressure on that mass. She was not
She was
comfortable.
not able to sit. And second thing, though she was catheterized, I
Yes,
hope you are
ma'am.
going to
Yes,
tell
ma'am.
me in the examination that catheter they have put inside in situ when she was admitted with the
Yes, ma'am.
cardiology or
Yes,
medicine
ma'am.
department. So still she was with catheter, but the patient party said that still in that bag also urine was not coming.
Yes, ma'am.
Because it was totally outside, bladder and neck was kinked.
Kinked,
Even
yes,
if you put the catheter, the bladder cannot drain anti-gravity.
Yes, yes,
okay.
ma'am.
Yes, ma'am.
So these were the two
Important.
more important complaints that I suddenly remember.
Yes,
That's what
yes,
she
ma'am.
said.
Yes, ma'am.
Okay. And now coming to the examination. So when you did local examination, a mass was seen
Right. Yes,
protruding.
ma'am. A mass was seen protruding, which was almost around like 6 into around 7 centimeters outside the introitus,
And Foley's catheter was
Foley's
inside.
catheter was in situ. Yes, ma'am. It was very tender to touch. When we tried to, because we knew it was a walled prolapse case, when we tried to reposit it, it wasn't going in. She was wincing in pain and she actually wasn't cooperative at all. Ma'am, then actually you deposited with one leading edge. Since it was more edematous anteriorly with the anterior vaginal wall, we took the posterior vaginal wall, slowly pushed the posterior vaginal
With
wall
lot of jelly.
with
a
lot of jelly.
lot of
Yes, ma'am. With a lot
And
of jelly.
actually, it's better to give her some painkiller.
Right.
You can give injectable painkiller or oral or rectal, whatever. First, otherwise, patient is not going to cooperate.
Yes.
Okay.
Yes. So with a lot of jelly, you reposited the posterior vaginal wall first, very slowly, and then slowly you reposited the anterior vagina. I mean, it was a wall prolapse, so at first posterior edge and then the anterior
Slowly,
edge.
slowly,
Slowly,
yeah, it
yes,
goes
ma'am.
inside.
Yes.
And then kept a tampon inside.
So you are not supposed to remove your hand.
Yes.
If you remove your hand,
It
you
will
don't
collapse
going to bite
outside
out,
again.
yeah.
Yes, ma'am.
Okay, so with your hand inside, you put a tampon
Yes,
from the
ma'am.
other hand.
Yes,
Okay. So this is one experience I would like to
Yeah.
share with you, that I have seen many cases who present as a case of incarcerated prolapse. Incarcerated means they are not repositable
Yes.
inside. But whenever they come, I don't know, somehow I feel personally that on a doctor's hand, no prolapses is repositable.
Okay.
Okay, if you try
Yes.
every prolapse, and many of the people who are practicing will agree to this thing. If you try, if you are a little
Patient.
patient, every mass can be reposited. And the treatment of incarcerated prolapse is actually reposition, the primary treatment.
Yes.
Yes,
Because the entire thing, the processes happen because of increasing edema there, decreased lymphatic drainage and stasis of lymph. That's why, like outside the introital
Yes,
ring,
ma'am.
it gets so edematous that it cannot come easily, and nothing is going to work till you reposit it back.
Yeah. Yes.
Okay, and it is definitely not advisable to operate the patient with that kind of prolapse because of that edema,
Inflammation and everything that
inflammation
needs
and
to
edema.
settle before the
Yes,
surgery.
Yes, and when you open it, also the anatomy is totally distorted. You
Yes,
don't
ma'am.
know whether the bubble loops are there.
Yes,
It was
ma'am.
a case of all prolapse. It
Yes,
was just
ma'am.
a
Yes,
bag.
ma'am.
Bladder is in front, bubble
And
is
bubble
in
is
front.
behind.
And then because of that ring of constriction at the introitus,
Yeah.
everything will be edematous, and what you are injuring you really don't know. So never take her up as emergency surgery. First reposit it, and according to my experience till now, maybe some patient I will see when I say this tomorrow, which I'm not able to reposit. But till now in my practice, I have not seen any case of prolapse which we were not able to put it back.
Yes, ma'am. Yes.
But suppose tomorrow a patient comes, in which case you asked me also that question, so
Yes,
I'm discussing it here.
Yeah.
Suppose if you are not able to
Reposit.
it back, I'm telling it to you in a
Yes,
different way, but I'll come to the question which Deera had asked me that day. So if you are not able to reposit it, okay,
Yes,
you
ma'am.
cannot, patient is jumping and chopping when you are trying to put it, and you tried 1 or 2 times, you don't want to increase patient's agony. What do you do?
And we can put a magnesium sulfate dressing with
Yes.
or mixed with glycerine, so that will reduce the edema and the inflammation. And then probably after 24 to 48 hours, try again to reposit
Yes.
after giving painkillers.
So make the patient recommend, put her in bed, okay? Because if she keeps on walking, doing activity
will
against the
stay out,
stasis
yeah,
and
yes.
all those things, it is going to stay out
Yes,
when she is lying down. But all venous congestion, lymphatic
Yes,
congestion will increase if she is all the time walking around. So put her in bed. Some people advocate lifting lower end of the bed also for tent elevation also, and that mass, cover it with gauze pieces which are soaked in glycerine, magnesium sulfate. Both work as hygroscopic, so they help to reduce little bit of edema. No antibiotic, no antiseptic is required for these you all
Yes.
know that. And slowly next day you try again. Once little bit of edema decreases, patient is in recumbent position,
Yes.
you will be able to
Reposit
the mass back. And as soon as within 2 to 3 days, the angry rocking prolapse becomes
Much better.
Much better, yes,
because the treatment is repositioning. When you reposit that mass,
Yes,
and you leave it there, it will, as soon as the patient stands, it will come back again.
Back again.
Yeah.
So you have to keep it inside.
Something,
That's
yes.
for healing or
Yes, ma'am.
edema to reduce. So you have to. So you can either put a pessary
Tampon or
inside
pessary,
or
yeah.
a pessary inside.
Yes, ma'am.
So in emergency, the size we were not sure. So
Yes.
immediate management is putting the tampon.
Tampon.
This tampon needs to be changed every day,
Yes,
2 times a
Yes,
day.
ma'am.
Yes, ma'am.
Okay. And after that, you were able to put a
Put a
pessary
pessary,
also.
yes,
ma'am.
So patients stayed with us pre-operatively for 4
about
to
4 to
5
5 days. Yes,
like this. And then we operated her after that. Okay.
Yes, ma'am.
So when you examination finding, you told me examination finding when it was angry looking.
Yes, ma'am.
The prolapse was around 7 centimeter mass, irreducible, no cough impulse. Anyway, patient will not
Yes.
allow you to do that, and you deposited that mass. After 4 or 5 days, when you see her,
Yes.
maybe we can say in OT,
In OT, yes,
what
ma'am.
were the findings?
Ma'am, the edema had definitely reduced. We couldn't examine
It had gone.
It had gone actually, yes, ma'am. It had definitely gone. It wasn't. The inflammation had also reduced. I couldn't tell the tenderness because she was under anesthesia then. But ma'am, the mucosa had also become
looked
a
healthy.
pale pink. Yes, ma'am. Otherwise, it was more reddish.
Reddish and
Yes,
angry
ma'am.
looking. So all this, and actually she has become more or less the way she was a month before when she
Yes.
has come as a consultation
Yes,
to
yes.
us. Okay.
Even her general condition when she came to us, she wasn't eating. Also, she was only on Ganji water. But after the reposition, like she even her intake
Started
was better.
eating, yeah. So investigation, you said so that
Yeah.
there was gross hydrourethronephrosis.
Yes, ma'am.
So when she had come to us for first time only around a month back, she had
Yes,
hydronephrosis
she did,
actually. Was there a change in this hydronephrosis and that hydronephrosis which you saw this time with ultrasound?
Ma'am, that time they had said it was moderate
And
hydrourethronephrosis.
this
When
time-
she came to her, it was gross hydrourethronephrosis.
So one very pertinent question Dheera had asked that time, which I did not think in that moment. She said that when they have put the stents, there should be either decrease in hydronephrosis or it should remain at the max same.
Yeah.
Why it is increasing when the drainage actually is happening.
Yeah.
So then later we found out when we did X-ray and the CT,
That
we
they
found
have
out that
the
the
stents
stents have got
migrated.
migrated. That can happen. That can be because of the severity
Pulling,
of
yes,
wall
ma'am.
prolapse.
Yes,
When the stents were done, then mass was reposited, and when it slipped out, again the stents got pulled out with the
And the condition
mass.
progressed.
Yeah, condition progressed. Okay, so if not taken care of in right time, it might cause renal failure.
Yes, ma'am.
Luckily, our patients'
She had
renal
pain
functions
and she came.
investigations we were talking.
Retained, yes,
Yes.
So her renal functions were maintained,
Yes, ma'am.
and serum creatinine was
0.5 and
0.5 and 0.7 in 2 occasions. So luckily that was the reason, and that was the scene for her renal functions. And so we planned surgery
Yes.
for her. Examination we have told, investigation important for confirmation of pelvic prolapse
Yeah.
or wall prolapse. You do not need any investigation, but we did ultrasound and CT
Yes, ma'am.
scan to find out her hydrourethronephrosis degree and blood investigation and other cardiac evaluation to plan the surgery. Now, more important point which I want to discuss with this case is how do you plan a surgery and what kind of surgery, what kind of management? Do you want to keep her with pessary?
No, ma'am.
No, ma'am.
Why?
We wouldn't want to keep her with pessary, ma'am. Firstly, because this patient, pessary requires, we can't keep changing the pessary like multiple times. In her case, already she's very frail. There's so much setting of infection. There are already so many comorbidities. It is better not to put a foreign object for such a long time. Also, advanced prolapse, pessary is not as effective. She has advanced
So
prolapse.
first thing that
Yeah,
comes
I should
to
have said that
first thing that comes to my mind is
There's no use.
pessary does not work for
advanced
wall
prolapse.
wall
Wall
prolapse.
prolapse. Yes, ma'am.
Yes,
She is
ma'am.
not a pelvic organ prolapse lady. She is a
Yeah.
wall prolapse. So pessaries usually do not work when the fornical area is not there, when the cervix is not there. Then pessaries usually
Will not
do
hold.
not hold. Okay, for small cystocele, for small rectocele, it might be of help. Then again, wall prolapse of this degree, pessary will not work.
Yes.
Okay, that is the first thing.
Yes,
For
ma'am.
some days it is okay when the patient
Yeah,
is lying,
lying down.
in bed, but every time patient cannot be. Second thing is definitely her cardia is already gone. Again and again you are putting some infection there.
Yes, ma'am.
And patient is, if she would have been so good with her follow-up, she would have come
Come
any
a lot
time
much
between
earlier. Yes,
20 years
Yes,
before.
Yes,
This
ma'am.
kind of patient you cannot take a chance. Once
Yeah.
she is happy, prolapse goes inside, then she will land up.
Yes,
Then
ma'am.
her urea creatinine gone only.
Yeah.
Okay, so
Yes.
you have to plan some kind of treatment which is the
Effective.
effective or
Permanent.
cure for
Yes,
her. Okay, one
Yes.
time cure and which is permanent. That we can do only with the surgical treatment.
Yes, ma'am.
Now, what major options of surgery you have for this patient?
Ma'am, for her we have both. We have the option of going in for either sacrospinous ligament fixation, sacrocolpopexy, abdominally or laparoscopically, and colpocleisis.
So we have 3 options for this patient. Abdominally, if you want, you can do sacrocolpopexy. Vaginally, if you want, you can do a sacrospinous fixation. And obliterative surgery is
Colpocleisis.
colpocleisis. She is 67-year-old,
Yes,
yes, ma'am.
not sexually active lady.
No.
Actually, even I gave it a lot of thought which
Yes.
kind of surgery we should do. It was not easy decision
Yes.
for me. So what factors I took into consideration and made a plan, that's what I want you to be thinking like.
Yes,
yes,
Okay?
ma'am.
So let's think for this particular patient
Yeah.
only we are saying if we do sacrocolpopexy,
Right.
that is abdominal or laparoscopic,
Hmm.
what are the positives and what are the negatives?
Okay.
What are the positives in doing sacrocolpopexy?
Ma'am,
for this lady?
the positives in doing sacrocolpopexy for a case of wall prolapse is that it
For
has,
this lady, we are not talking of
For
any
this
case
lady,
of.
okay.
It is done for wall prolapse.
Yes,
right?
ma'am.
Yes.
We are talking about this 67-year-old lady.
okay. Ma'am, one thing is that it is the most efficacious.
Yeah.
So the
Efficacy is very good.
yes, ma'am. That would have been one benefit of doing sacrocolpopexy in this patient.
Okay.
Yeah.
What are the disadvantages? But we did not do.
We did
Yes,
not.
ma'am.
Okay.
Yeah.
If you see efficacy wise, maybe very good efficacy it has.
Yeah. But we
And
need
it
to
would
have a
do-
holistic picture.
Holistic picture. So, what are the why we did not do sacrocolpopexy?
And one, it is a more invasive surgery. It would take us a longer time to do this
Yes.
surgery. Ma'am, for laparoscopically,
So she is
wouldn't,
not a medically fit patient.
Yes, ma'am.
If you can recollect her cardiac status, whatever they do, I
Yeah.
can see only one thing for cardiac functions.
Ejection.
And ejection fraction.
Yes, ma'am.
Ejection fraction more than 40, I am cool to do a surgery. Ejection fraction
Hers was
less than
30.
40.
Yeah.
I am little conservative.
Yes, ma'am.
Her
Yeah.
ejection fraction was
30.
33% or
Yes,
around
Yes,
30%.
ma'am.
So it was not a very good candidate for longer anesthesia
Yes.
and pneumoperitoneum.
Peritoneum, yes,
Okay.
ma'am. She wouldn't-
Laparoscopy, she was definitely not
Not
a
a candidate.
candidate. Open, okay, but again taking long time.
yes,
And
ma'am.
one more point.
And
If you
she's
remember,
Ma'am,
diabetic.
she is sexually.
she is diabetic.
Diabetic,
Second
yeah.
point, but diabetic also. Okay, diabetes. I prefer an abdominal procedure in diabetes because in this kind of advanced prolapse, because the mesh
Mesh will hold
hold
it.
it at multiple points. When you are
Right.
doing sacrocolpopexy, we are just holding it at 1 point or max 2 points.
Yes.
Yes,
Okay. So we have seen little bit more failure rate if diabetes is not controlled.
Right.
Okay. Diabetic, you don't want to enter the peritoneum. I'll take
Yes.
that as a point.
Yes, ma'am.
One more important.
Ma'am, also abdominal sacrocolpopexy is something we're doing for patients who are younger and where
Okay.
we want to retain the sexual function and want a longer vaginal length.
Yes.
That wasn't a concern
That
in her
wasn't it,
case.
but we wanted a efficacy. I
Efficacy,
wanted
yes,
a
ma'am.
one good procedure for
Yes,
her.
ma'am.
So tell me one more point.
For sacrocolpopexy, again
Again,
sacrocolpopexy.
Again, sacrocolpopexy. Why we did not do? You know it.
Ma'am, entering peritoneum, we did
That
not.
you told.
Okay.
She had some history.
Oh, ma'am, she had a history of abdominal tuberculosis
Yeah.
for which she had taken treatment for a year. Although her documents were not there, but the brother had clearly said that she take treatment
So
for
she was a
ATP
treated
for a year.
patient of tuberculosis. She has undergone hysterectomy. So we expected a lot of adhesions.
Adhesions.
A
Yes,
much longer time in doing the procedure.
Surgery, yes, ma'am.
And you never know. I have seen 2 patients who had flare up of tuberculosis post surgery.
Yes.
So healing and all those things are never very good. So that was also one risk factor. So definitely she was not a candidate for lap surgery.
Sacrocolpopexy.
And now we have ruled out
Abdominal
abdominal surgery also.
Also.
Okay, so we have to do something from the vagina.
Vagina.
Yes.
Now,
ma'am.
what procedure you want to do from the vagina is the question. We
Yes,
have
ma'am.
2 procedures now:
Huh.
sacrospinous
Spinous.
fixation,
Yes, ma'am.
all obliterative surgery, which is
Colpocleisis.
colpocleisis.
Yes, ma'am.
So, which one? What are the points for sacrospinous fixation and against sacrospinous fixation?
Ma'am, again, sacrospinous fixation. For sacrospinous fixation, it will be that it is more like the vaginal length that we obtain after sacrospinous fixation is more than in the
Yes.
case of colpocleisis. And it is
Advantages are we are not opening the
Yes,
peritoneum
ma'am.
here, but we are attaching it to a fixed
Fixed point.
Yes.
Yes, ma'am.
We are attaching the ball to a fixed,
fixed point. Yes, ma'am.
Okay, so the efficacy is not very. If you
Yeah.
say it's not very lower as compared to abdominal sacrum. If that has 97, it has also 95.
Yes, it's comparable.
Comparable.
Yes, ma'am.
Okay. What are the negative points? Then why we did not do a sacrocolpopexy, sacrospinous fixation for this
Yeah,
patient?
yes. And one that since she's a diabetic,
Yes.
and if it's uncontrolled diabetes,
And I
if they're
was
not
worried
getting-
about her reliability.
Yes,
Hmm.
ma'am.
Okay,
whether
because
yes, ma'am.
whether she was usually when we do sacrospinous fixation for women who are having diabetes, I strongly say that 1 month
Of
nothing doing
insulin.
insulin
Yeah.
you
Very
have
good
to
control.
take. Why? Because when we are putting 2 sutures, it
Yes,
is
ma'am.
anchored on one side only with 2 sutures.
Yes,
And
ma'am.
vagina, you know, is a home for various bacterial flora and microorganisms. And those not a little exposure also, if sugar levels are not controlled, bacteria will populate there with that foreign body and eat it up.
Yes.
And one suture has to be there for at least 6 to 8 weeks for that healing
And
and
fibrosis.
fibrosis to happen of the vault with sacrospinous ligament.
Yes.
If before that only the suture, anchoring suture is eaten up by the bacteria, then there is
A failure.
a failure. Okay. We had one patient like that who refused to take insulin, who promised to us that she will take insulin, and when she showed her chart, all haywire sugar levels were there, going up to 300, 350. She was the only one case in last 2 years where we had, like recent time, where we had a failure and rate to cystocele, a recurrence of vault prolapse in there. And when you examine the prolapse, vault has actually come down. It is, nothing is holding it. And I actually attribute it to because of our sugar levels, infection, and eating up of that suture by the bacteria, and vault coming off the sacrospinous ligament.
Yes, ma'am.
So her sugar levels were also fluctuating,
Yes, ma'am.
and she was not
And
a
her
good candidate.
compliance was questionable.
Compliance is the word which I was looking for.
Yes, ma'am.
Reliability, when I said compliance was not
Questionable.
reliable,
Yes,
not
ma'am.
questionable.
Yes.
Yeah, it
It
was,
was
questionable.
questionable. Yes,
Sorry.
ma'am.
So that's why we thought that just doing sacrospinous fixation,
Yeah.
anchoring at one point
Might not
was-
work for
might
her.
not work for her. Now her important question,
Yes, ma'am.
important thing was her not able to sit. Definitely the mass was bothering her.
Yes,
Yes,
ma'am.
ma'am.
She was not even able to
Sorry.
sit, and she was having urinary complaints. So we thought that we'll do colpocleisis, and
Yeah.
colpocleisis is not just closing the vagina, it is pushing the organs which are lying outside the body, laying outside the body to inside the
Yes.
pelvis. Okay.
Yes.
So we decided finally that we had to help her, and we'll do colpocleisis. And colpocleisis will have advantage that all the organs will go inside. She will not have problem of mass hanging outside,
Yes.
and bladder will be repositioned back into the pelvis or in the vagina in the pelvis. So she will not have voiding dysfunction.
Yes.
So thinking all these, we planned for her surgery.
Yeah.
She was not a very good candidate for anesthesia. Still, she required a surgery. We could not have done with a conservative management
Yes.
for her. She has already started developing hydroureteral nephrosis.
Yes, ma'am.
Already stents have failed
Yes.
in her, so we had to do the surgery.
Corrective surgery.
Correct.
I mean,
Some kind
some
of
kind of
surgery
surgery.
for her. So
Yes, ma'am.
that to reduce her symptoms and the mass. So we planned a colpocleisis
Yes,
for
ma'am.
her.
Yes.
So pre-operatively, now her
Yeah.
stents are already come out.
Yes, ma'am.
Okay.
Yes.
So what did we do? And she
Yeah.
had hydroureteral nephrosis.
Yes, ma'am.
After surgery, edema congestion will increase.
Yeah.
So it's better to put stents,
Stents.
whenever there is hydroureteral nephrosis
Nephrosis.
in these kind of women.
Yes, ma'am. Ma'am, okay. Pre-op
Yeah, ma'am. So in the morning of the
preparation.
surgery, the displaced stents were removed and stents were again reinserted so that the kidneys are decompressed and for the resolution of the hydroureteral nephrosis. And after the placement of the stents, she was shifted for the definitive surgery of colpocleisis.
So hydronephrosis will decrease with ureteric stenting, but it will not suddenly go away.
Yes,
The
ma'am.
kidneys will not become normal. Actually, we requested for early 2-3 days before only stenting, but the urology people, they had a valid point
Yes,
that it is because of the prolapse coming out,
Yeah.
and if they put it again, it might get displaced. So
Displaced.
it was better to do it the day, morning in the day
Yeah.
of surgery.
Yeah.
So it was done.
Yes.
Then after that, we did colpocleisis.
Colpocleisis.
So it was not a colpocleisis for a 3rd degree or 4th degree uterine prolapse. It
Yeah.
was for a vault prolapse.
Vault prolapse.
So some important points you would like to recollect and
Yes.
tell the viewers what are the important differences
In the case of colpocleisis being done for this. Okay. So ma'am, in this colpocleisis, firstly, this was different because till now what we had done was partial Lefort's colpocleisis, which is done with the uterus being in situ. This was a colpocleisis where we had done it for a case of vault prolapse. Also, this patient had so many comorbidities. She was a very fit candidate for colpocleisis. She was elderly. She had so many comorbidities. We wanted to do a surgery that is not very time consuming, and we do not need to give a longer anesthesia for. In this colpocleisis, we had
So what kind of anesthesia did we give?
Ma'am, we gave her a general anesthesia. They
Why not?
avoided.
Spinal or regional anesthesia would have
Yes.
been better.
Ma'am, that would have been, that's what we thought initially, but then after discussing with the anesthetist, they said that if we give a spinal anesthesia, then there can be, if there's a sudden hypotension and she's already in
The
failure,
heart will not be able to tolerate
tolerate
it.
it.
Yes, yes.
So short GA was better for her as compared to even
Yeah.
spinal anesthesia.
And after that, we started with our
Surgery, tell only what is the difference. We are not going to discuss because we have done that before. We have posted videos also.
Yes,
Can
ma'am.
give what is the one difference when you do a colpocleisis for wall prolapse versus with uterus?
Ma'am, the most important difference is since the uterus is not in situ, we do not require anything. We don't require those tunnels to drain out any secretions because the uterus is not in situ. So we do not need to put a Ryle's tube like we put in our cases usually. And also we had done the obliteration with the help of purse string sutures rather than with interrupted sutures incorporating both fascia and the vaginal mucosa.
Yes. So it was very clearly told that we don't have, when uterus is there, there can be some collection, some secretion in the uterus, and if we don't take care of it, we don't give it draining channel, it will get collected inside, get infected inside, and can make pyometra sometimes.
Yes,
Okay. So there we put a
Ryle's
tube, Ryle's tube, and the
Create the
vaginal
tunnel.
mucosa is around that is sutured,
Sutured.
and we ensure that the tunnel remains patent
Patent.
throughout the surgery.
Yes, ma'am.
Here we do not have anything like that.
Yeah.
So many people, what they suggest that denude the entire epithelium. Okay, in 2 squares or in 4 squares. You can put 4 incisions and put 4 squares and denude the entire vault of its vaginal mucosa, and then keep on putting successive postural sutures. The surgery is faster and it goes inside. But maybe it is our modification of doing colpocleisis for wall prolapse that we still try to keep a few strips
Yeah.
Yes,
of
ma'am.
vaginal
Yes.
rectangular strips
Yes.
on the sides.
Yes, ma'am.
Though we don't create tunnel, but we give. The idea behind that is those are the attachment. There are two
Yes.
things: the
Yes,
attachment of uterosacral mecanthus ligament, whatever.
Some support they will provide.
Yes,
Daily, what do you say? How much ever weak they have become.
Yes,
Yeah.
ma'am.
At least some fibers
Something.
might be of help in
Yes,
pulling
The
the mass
vault,
up,
yes,
the
ma'am.
vault up. And the other thing is, these positions, that 9 and 3 o'clock position, are the position of vessels also.
Yes,
Okay,
ma'am.
yes,
So
ma'am.
if you try to denude entire thing, you might have more
Cause some kind
bleeding
of trauma.
and
Yes, ma'am.
blood vessels are there. The third reason is just putting purse string sutures. So
Yeah.
what we did again.
Yes, ma'am.
Yes.
So not a tunnel form, but which was like this.
Yeah.
We inverted and then
Yes.
put it with our suturing
Yes,
inside.
ma'am.
On top of that,
We have
did-
done purse strings
Purse
to
strings.
obliterate.
Yeah, just purse string might not be that effective.
Yes, ma'am.
Putting the
Making
inverted
that
U
tunnel,
into
yeah.
normal U, and then
Yes.
putting purse string might have added advantage.
Mm.
And as we saw also with this surgery, we still got a depth of around 4 centimeters
Yes,
at the
ma'am.
end of our surgery.
Yes, ma'am.
And the vault appeared well suspended
Well
as of now. The patient is yet not discharged from the
Yeah.
hospital. Will be giving you a feedback when she goes back and comes for a follow-up. Okay,
Yes,
and
ma'am.
then we incorporated it with
Perineuraphy.
perineuraphy. Okay, and the ultimate result was good. Patient
Yeah.
is doing fine, and
It was a short surgery.
It was a
The
short
anesthetist,
surgery.
the anesthetist was also very happy.
Okay. Okay, so till now everything has gone well. Today we have removed the catheter of the patient.
Yes, ma'am.
The patient will be able to pass urine comfortably. She looks happy.
Yes, ma'am.
Okay, so after this
Yeah.
entire discussion, as always, I will again ask you if you learn some point, maybe just two points if you tell,
Yes.
that will be good enough from this case.
Ma'am, one is that during the surgery, what you said that we maintained the rectangular strips. I thought it was only for the support, but to avoid the bleeding also, that was one point.
Okay. From today's case discussion, so we learned something.
Yes, ma'am. Ma'am, that our pre-op preparation is also very, very important, and we should think of usually when we are looking at the anatomical defect, but we also learned that the other problems that she can have, like her kidney function was getting so compromised, and this was a bigger reason for us to do this surgery for us. So we should be careful of that as well. Yes, ma'am. And this was a very multidisciplinary approach that we had involving anesthesia, cardio, urology, us. Yeah.
And it is the more and more women are entering into this age group. Urogynecologists will have to face these kind of situations, and then we really have to involve everybody,
Everyone.
and then think which plan of
Yeah.
management suits best for
Yeah,
this
patient
particular
specific.
patient.
Yes,
Okay. So I think you also learned something today with this case discussion. So soon we'll come back with another interesting case. We have a few cases lined,
Yes,
but we are
ma'am.
not having time to discuss those. So hope to see you soon. Thank you so much.
Thank you.
Thank you.